Hello everyone, and thanks for coming. This presentation is going to be about the hazards of using glue for wound repairs. My name is Harry Karibas and I have no social media accounts because I'm not looking for hits, subscribers, likes, followers or any other means by which to become a social influencer. Mainly because I don't look good in a bikini and I prefer to eat my food rather than photograph it. But if you want, you can always contact me through my email address. My talks always contain a warning, and if any of these elements that may appear in the talk offend you, please feel free to leave now. Everyone gone? Okay, on we go. No presentation about skin would be complete without, at the outset, showing a picture of skin. Skin is the largest organ in the body. It's a multi-layered, multifunctional, complex structured organ. People come to the ED because of many skin problems. It may be too red, too white, too hot, too cold, too spotty. There may not be enough, or some may be missing. There may be too much, or may have come apart, as in wounds. The management of wounds has been an issue for many centuries. People present to the ED with wounds in the hope of some sort of closure. So what is the purpose of closure? It's to restore function, improve cosmesis, reduce healing time, reduce scar tissue. The principles of closure are to oppose all layers of the same level at the opposite side. And it's to reduce dead space. There are multiple methods of closure: suturing, adhesives such as steri-strips, bandages, glue, nothing, and others. So, as I said at the beginning, this talk is primarily about glue, which, as you can see from these photos, it's not inexpensive. Now we're going to watch a little short video from the manufacturer about how to use glue.
Simple to use and effective, Histocryl topical skin adhesive is the proven choice for wound or incision closure. Histocryl is applied in a single layer and sets in about 30 seconds. Histocryl tissue adhesive begins to polymerize in contact with moisture and doesn't require a multi-part applicator with a catalyst or activator like other tissue adhesives. All you need to use it is right in the single-use ampule. Histocryl is supplied in foil peel packets, which are common with other sterile medical products like surgical sutures. To open, simply pull apart the ends of the foil pouch to expose the sterile ampule. To open the ampule, hold it securely as shown, then twist the tip a full revolution until it comes off. Without squeezing the ampule, turn it over so the applicator tip is pointed down. Then gently tap the ampule to load the tip with the adhesive. Check the wound or incision to make sure the edges will come together easily with little tension. If this is not the case, relieve the tension using subcuticular sutures. There are two main techniques that can be used to apply Histocryl and close a wound. The first one we'll demonstrate is called the drop and drag method. When using this method, hold the edges of the wound or incision together. Lightly press the base of the ampule to apply a small droplet of the adhesive above the wound or incision line. Continue applying droplets in the same way. Use the neck of the applicator tip to connect the dots and drag the Histocryl over the entire wound. Only a thin layer is required. Once the adhesive is spread out, you're done. The other method is a continuous flow technique. All the preparation for this technique is the same as before, only the application differs. To apply, squeeze the adhesive out in a continuous layer while moving along the wound or incision. You must maintain a positive pressure on the ampule during the entire application process.
So the key points that you should get from that short video are that glue is to be applied in a single layer or a thin film. It takes about 30 seconds to set, and if the edges are not close enough, then subcuticular sutures should be used and then glue, which really begs the question, if you're going to be suturing, why would you do a two-step process with a product that has potential harm and complications? And I want you to remember all this for later in this presentation. So why has this presentation come about? Well, it'd be nice to do it because a patient presented with an infected dog bite after it had been glued, and the complication required the patient to go to theatre, and fortunately made a good recovery. And from this it was determined that education about glue is required. Now, I disagree with this. The problem is, in this case and in others where glue has been implicated, is not fundamentally a glue problem. It's a decision-making problem of when to use glue or patient selection. And this has been very disappointing to me, because I gave part of this talk at a presentation at the Eastern Health Forum in 2017. I gave it as part of a presentation in 2019 and another presentation in 2020. It is disappointing to have to give this talk, because I've given most of this presentation in other teaching sessions for a very long time. But at the end of the day, on YouTube I watched a presentation by Greg Henry, an American emergency physician and well-known speaker. He was spouting the same stuff that I heard him spout about 20 years ago. Perhaps I could also make a career out of giving this glue talk. So what is the problem with gluing a dog bite? So what is the problem? It's basically poor understanding about the implications of history, examination findings, and limitations of the history taking and examination findings, in addition to the limitations of the therapies that are proposed. This is an animal bite. Animal bites are often deeper than they would appear on the surface of the skin. As such, they are difficult to examine, especially in children who may be non-compliant and combative. Because of the hole being small at the skin with deeper tissue damage, it's actually very difficult to wash out these wounds properly in the ED. Hence often the referral to plastics. Or if plastics isn't available, then surgery. If in doubt, it's best therefore to leave them open. It won't matter in the short term or in the long term. It is better to have a slightly bigger wound that's not infected than a bigger wound that's infected. At the most, you can apply a steri-strip. Glue is probably the worst option because it actually seals in every germ that's in there and provides no point of discharge for any collections that may develop. If a collection does develop, then it's actually very difficult to remove the glue to allow for discharging of the collection. And if you compare this with sutures, sutures can easily be removed and steri-strips will generally fall off. Medical practice, though, depends on cake. And this is a little acronym that I've developed to help me understand why people do things. It stands for competence, not only as a doctor, but also as a person. Attitude, are you prepared to do what's easy or what's right? Knowledge, which may be both theoretical and practical, which is sometimes referred to as experience. Not only experience in medical matters, but also life experiences. And life experiences help you understand the patient's perspective. Sometimes this is referred to as empathy. Now, these 4 factors in medical practice are completely interrelated. So your competence depends on your attitude, which affects your knowledge. Your knowledge, therefore, allows you to gain more experience, which in turn improves your competence. So to what standard is medicine practiced? Is it based on education and training? Is it based on evidence? Is it based on something else? And for those of you who have heard me talk about this, then you'll know that I like to coin the phrase social normative behaviour. So social normative behaviour is defined as the influence of other people that leads us to conform in order to be liked and accepted by them. In this case, to have our treatments and managements of patients liked and accepted. It's a basically monkey see, monkey do attitude. There's supposedly safety in numbers if you follow what everyone else does. But together we stand and divided we fall. But the major problem is a lack of problem identification and solving approaches in favour of the easiest if this then that mentality, or the McDonald's approach, which is I want it hot, I want it fast, I want it now. Just in exchange for some quality. This is a screenshot from the ED intranet from 2002. I started teaching, or preaching rather, about the hazards of glue very early on. So even though this is from 2002, the preaching started sometime before that. On that intranet site, the major pros and cons of histoacryl glue were actually outlined. And if you note that really very little has changed in that time, same problems have continued to arise. So is glue the problem? Glue's not the problem. The problem is the person using the glue, and particularly their patient selection. Is it a failure of education? It's a failure of training. It's a failure of supervision. It's a failure of the individuals to self-educate. It's the failure of the system to monitor all this. It's a failure of providing feedback to individuals that may be using it inappropriately. And it's a failure of audit systems. So how many patients do we actually glue, and how many of those patients actually have problems? Well, there's no way of actually knowing. And all this despite all the time and money spent on education and training. So glue is not the problem. I'd like to begin this with this case presentation from a little while ago now, which started off the ball rolling with the this presentation dating back to 2017. If you note from the triage assessment, this patient presented with a lac to the left second finger on metal a few days ago. He was seen at the tertiary hospital ED and was glued. The bleeding started the next day, and he was told to come here because it might have required suturing. So the question is then, in which circumstances can glue be used? And we can get some understanding from the manufacturer's website. The indications are it can be used to hold easily approximated edges of minimum tension wounds from clean surgical incisions and simple, thoroughly cleansed trauma-induced lacerations. It can't be used in place where sutures might be a better option. Contraindications. It's not to be applied below the surface of the skin. The reaction is exothermic, so it may it's not to be applied below the surface of the skin because it's not absorbed and may elicit a foreign body reaction. It's not to be applied to any internal organs or to any wet areas, such as the mucosal surfaces or mucocutaneous junctions, or in areas where there's dense natural hair. And this seems to be a little bit of a problem because one of the commonest sites where glue tends to be applied is in the scalp, where there's an abundance of dense natural hair in most cases. It's not to be applied to the surface of the eye. I can't imagine why you would actually think about doing that. And it's not to be applied to high skin tension areas or areas of increased skin tension. And by that, it's meant over areas where there's lots of movement, such as the elbows, knees, or knuckles. And it's not to be used in areas where there's skin missing. It's also not to be applied to any wounds that show any evidence of infection, gangrene, or wounds of decubitus nature, so no pressure sores. And to this I would add potential infection, not just established infection, such as the dog bite that we saw earlier. And it's not to be used in people with poor wound healing or with preoperative systemic infections or sepsis. And it's also not to be used in patients that are hypersensitive to any of the components. But I don't know how you would find out unless they've had it before. So in addition to the contraindications, there's a whole bunch of warnings. It says that the glue's got to be used on wounds that have been thoroughly cleaned, debrided, and have easily opposed edges. It should not be applied to tissues that may be affected by heat because it gives off heat as it sets. It's to be used very sparingly as a thin layer if you apply a heavier layer, then there's a risk of thermal damage and delayed healing as a result. It's not to be applied to wet wounds because this gives off excessive heat again. It may result in localized sensitization or irritation reactions. And again, how would you know before applying it? So therefore, why would you take the risk? Application or migration leak. So things that leak just below the surfaces of the tissue edges form a barrier to healing. And this is likely in a lot of wounds that present to the ED, which are lacerations or created by impact, which has a tendency to invert the wound edges, therefore making leak subcutaneously more likely. If it's the blue version, then the leak underneath the skin will create tattooing. And of course there's also the danger of accidentally bonding, usually to the guy or woman who's applying the glue. And there's a whole variety of means of which to attempt to remove it. And you may actually stick bits of skin together that you didn't want to stick together. So in addition to the contraindications and cautions, then there's also precautions. So they need to be kept dry following closure with histoacryl. And that's in direct contradiction of what was stated in the earlier advertisement that said you can shower with it. It's also not being evaluated in people who tend to form keloid or hypertrophic scars, and that tends to be predominantly the people with darker skin who are at higher risk. So if you use too much, basically you can cause tissue damage. So after all those contraindications, cautions and precautions, why would you actually take a risk of something going wrong instead of just using one of the centuries proven wound repair techniques? So back to this, we can see that the wound's still very dirty, so it's not a thoroughly cleansed or cleaned wound. The edges show some evidence of where the glue was, and it wasn't applied to the entire wound as a thin film, quite clearly. It's over a knuckle, so it's a moving part, so it's got extra tension and therefore doomed to have failed. Here are other examples where it was used inappropriately or applied incorrectly. So in this case, this wound here was the reason for glue being applied, but it trickled down through the eyelid and stuck the eyelids together. Eventually this just came apart. In this example from a tertiary children's hospital, this patient presented to a peripheral hospital with the complaint that the wound has not healed after 2 or 3 weeks after the application of glue. And the issue here is clearly that the glue has formed a barrier to wound healing by having been applied underneath the surface. In this example, the child's fallen over at home early in the morning, went to the GP, got it glued. An hour and a half later, or 2.5 hours later, it's split open again. Again, this is probably an inappropriate selection of wound for glue, in that it's actually very quite deep, and children pick at it. You can see a small amount of residual glue on the end there. This is a very interesting case of a girl with a stiff neck presenting to the ED after a fall. The girl, a child, had slipped by the poolside, had a head wound glued by the local doctor, and arrived with the major complaint of not being able to move the head properly. So this is a picture of the glue of the wound, as photographed by the mother and sent to me for purposes of education and training. And you can see that it's been quite a deep wound and really inappropriate for gluing. But gluing that they attempted, and this is the outcome on presentation to the ED. You can see that the wound edges have not stayed together, not unexpectedly. They've split apart. There's a bit of glove stuck to the wound where the operators actually stuck themselves to the patient, and to free themselves they've cut off bits of the glove. And the reason for the stiff neck is that the glue had trickled all the way down to the neck, so every time the child moved the neck there was tension on the skin, preventing the child from moving the neck properly. And this child had to go to theatre to have all this wound debrided, the glue removed, and the edges of the wound cut and stitched together onto plastics. This is an example, again, photo supplied by the parent before treatment, who arrived sort of 4 or 5 days after glue was applied. And again, this is an inappropriate wound for treating because it's not a simple, unopposed, easily opposed edged wound. From this picture you can see that the edges haven't come together, and actually glue has gotten into the wound, creating some irritation, hence the redness, but also it's not been applied in a thin single layer of glue. So again, not a glue problem per se, but poor patient selection and poor application of the glue. I had my doubts about whether anyone would apply glue to these wounds, as the patient had stated on her presentation, but for the fact that there's actually histoacral blue on the skin edges there. Again, inappropriate use of glue in this circumstance. In this example, the parents presented for wound repair of another body part and highlighted the fact that they didn't want any glue because of the poor cosmetic result from this wound that had been glued some years earlier. That actually had fallen apart after the glue had been applied. Again, not easily opposed edges, and it's not a simple straight wound. It's sort of a angled wound there. Again, inappropriate, not simple, not easily opposed. It's deep and over a moving part. So glue doomed to fail. The problem here is the edges of the wound don't come sufficiently close together, and therefore the wound has been prevented from healing properly by glue getting into the edges. I'm told that possibly the resident here didn't actually know how to apply glue and merely put glue in the wound and held the edges together, but I'm not able to confirm this. From a nurse, and I'm sorry I don't have any pictures, an Angliss ED nurse working at a local GP also calls up, says, what do I do? The GP doesn't know. What had happened was that they had their patient had a scalp wound sutured at another site, and on top of the sutures they put in glue. The patient then presented to have the sutures removed, but you can't get the sutures out because there's so much glue. So there are other problems with the glue. It stings, and mostly because wounds aren't completely dry, and as soon as some of it gets in a wound in a child and it starts stinging, the child becomes distressed and uncontrollable on many occasions. And remember, it takes about 30 seconds for the wound to set, for the glue to set. Once a child becomes combative, it makes glue application very, very difficult. They need to be held down and restrained. All this combativeness makes misapplication even more likely. So therefore it's not necessarily quick. 30 seconds is a relatively long period of time, and time is relative. So I'm going to show a short video and ask you the questions of how long is the ride, and imagine you are the rider.
Rodeo riding has never been for the faint-hearted, but when it goes wrong, it can turn into a blood sport. Alex Turner was among the first bronc riders at the National Rodeo Finals on the Gold Coast, but his ride did not go according to plan. Believe it or not, this morning Alex had recovered and will do it all over again at tonight's event. Suzanne Kovacs for couriermail.com.au.
So the question really is, how is that any different to holding a wound together in an uncooperative child? The rider lasted less than 20 seconds on the bull, and it took maybe another 20 or 30 seconds before he can be rescued. So a long time. So I do have a confession. Yes, I do use glue on occasions, or at least I have, but this is very rare. I've never used it directly on the wound or on the wound edges. I've used it to hold hair ties down, applying the glue to the knot so it didn't slip, and this is generally nowhere in the region of the wound. I've also used it to hold the edges of the steri-strips down, again the glue being applied nowhere near the wound edges. And there used to be a thing called Friar's Balsams, easily available in the ED, where it was painted on either side of the wound, and it would make stickiness of the steri-strips far more solid or far more sticky, so the steri-strips wouldn't be removed. And this was a good option for a lot of wounds that didn't need stitching. And supposedly it was removed from EDs because someone mistook it for betadine and applied it in the wound, which had disastrous consequences. And as a result, it's really hard to get Tink Bensco for the purposes of making steri-strips more adhesive. Therefore, beggars the question as to why, after more than one bad outcome with glue, is glue not actually removed from EDs. I have used it to remove a foreign body from the ear, being a small plastic ball from a pearl necklace, or a pretend pearl necklace. Used a dab of glue on the edge of a drawing up needle in a very cooperative child, allowed the glue to set, and then pulled it out with the needle after the super glue adhered to the needle, to the foreign body. I've used it to repair my shoes and glasses, and I've heard that some nurses use it for their artificial nails. So the mistakes with glue are based on cognitive biases. The first one is confirmation bias, and this is our tendency to forget about all the bad outcomes and only remember the good outcomes of using glue. It's also based on anchoring bias. An anchoring bias is a cognitive bias that causes us to rely too heavily on the first piece of information we are given, such as, oh, this is a very simple wound, it'll be right for glue. So that's like getting permission to just use glue. The availability of glue in a department is also a form of anchoring bias. Then there's the Dunning-Kruger effect. The Dunning-Kruger effect is a polished cognitive bias stating that people with low ability at a task, such as applying glue, or knowledge of when to apply glue, overestimate their ability and are unaware of their relative lack of knowledge. And coupled with confirmation bias, creates a perfect storm for inappropriate use of glue. Now, in addition to that, what complicates or makes it more likely is the imposter syndrome. And the imposter syndrome is basically the opposite of the Dunning-Kruger effect, where senior staff who are meant to be supervising junior staff just generally assume that everyone has the same knowledge as they do, which is not often the case. So therefore we don't bother checking to see if the wound is appropriate to be glued, or whether the person applying glue has adequate knowledge in that area. Now, I can be accused in this presentation of exhibiting negativity bias. Negativity bias basically can be explained by the example of if you have a 25-year-old car that you never service, and one day you get in, try and start it up, and it doesn't start. Then you ask yourself, oh my God, what's gone wrong? Instead of asking yourself all the other days before when it did start, well, what's gone right with this car that starts regardless of me not having had it serviced for forever? So in some ways it can be thought of as the opposite of the confirmation bias. So is the answer education policy, or is it something else? So in order to avoid complications with glue, the only real solution is to remove glue completely. Because as Douglas Adams of Dilbert fame said, a common mistake that people make when trying to design something completely foolproof is to underestimate the ingenuity of fools. So what does the future hold? Well, I will predict that while glue is available, complications will still occur. And if you like, you can email me your de-identified pictures to include in future talks. My view of banning glue from EDs is in the minority. Most other people don't see it as a problem and will continue using it. So my question then is, if one person from a smaller department can actually accumulate this number of cases in a relatively short period of time, how many others could there be in the rest of the world? This article was published in a recent edition of Avant. Avant is Australia's largest medical defence organisation, or medical indemnity insurer for doctors. And basically, in this case, a GP registrar was pressured by a patient's mother to have a eyebrow wound glued when the doctor would normally have used Steri-strips. A complication arose where a small amount trickled on the child's eyelid and dried, and as a result the lids became stuck together and wouldn't open. Sounds like very similar to what had happened in one of the previous pictures that I showed. They were referred to the ED, certain things were done, the eye was opened, and there was no long-term consequences. So, as a realist, what do I think the impact of this presentation is going to be? Remember, I'm in the minority, so I don't think there'll be any impact. And that's because part of the reason is that it's easier to fool people than to convince them they're being fooled. Thanks very much.